Our next speaker, our keynote speaker, is Joel Segal. He worked for Representative John Conyers as one of his senior advisors from 1999 to 2013. And in that capacity, he co-authored H.R. 676, the Expanded and Improved Medicare for All Act, which many advocates consider the gold standard for healthcare reform. He is a movement builder and has insider knowledge of how to create change legislatively. I want to thank him so much for coming all the way from Charlotte to talk with us tonight. Joel Segal.
Hello, Chapel Hill. You ready to go to class? All right. I'm going to give you a little bit of context about how this bill was written, because it's really important. Once you understand how it was written, you'll be able to, I think, explain it to people. If you can't explain a bill, it's very hard to go anywhere if you can't defend it. But I got hired in '99, and Mr. Conyers heard me speak. I launched the universal health care movement after being kicked out of George Washington Hospital. I was born with 3 disabilities that I suffer with now. And these are all the bills that I owe. See all these? It's $150,000 in medical bills. Yeah? Anybody want to organize a bake sale for me? So it was Bernie Sanders and Barney Frank, and I was the patient activist speaking about what it was like being uninsured, and I talked about my mother and how she lives in poverty as a result of paying my bills, and I got very upset as I was speaking in public, and it's hard for me to, I don't know why, it's hard for me to get upset and cry or whatever, but I got very lucky, and I got hired by Mr. Conyers. John Conyers is the genius, really, who came up with this bill. He wanted a strong federal single-payer bill. Give him a round of applause. He didn't want a state-based bill because he predicted that governors wouldn't take the money. He was so right about that, right? And so I'd studied the Medicare program, and I was thinking, how can the Medicare system be expanded and improved to deliver a single-payer bill? Because if you say single-payer, people say Canada, long waiting lines, right? That wouldn't work. But if you just say Medicare for all, everybody knows what Medicare is, right? So there was a doctor named Harvey Fernback who said, just call it Expanded and Improved Medicare for All. And I'm like, man, that makes sense. And so the bill was written from 2 perspectives. One was from the patient perspective, was how do you have a system that has no financial barriers to care? What's the first question they ask you when you go to the doctor's office? Right. I call it a wallet biopsy. You know? Do you have insurance? No. And then from the other perspective was I wanted to write a bill for Mr. Conyers that the doctors would be for. Well, why is that? Because who's the first group that's going to come out against your bill and destroy it? It'd be doctors, right? So I figured if you fuse a patient-centered, doctor-friendly bill, that would withstand time. It's 2017. We introduced the bill in 2003, so I think we were right. What do you think? Patient-centered, but doctor-friendly. And I think the reason why the bill is a good bill is I wanted to write it real short. And I printed it out this morning. It's 10 pages. Well, why is that? Because Trump said it's real complicated, right? He said, man, health care is all complicated. No, it's not, Brother Trump. You just don't know it. It's real simple. You got to go to the doctor, and someone's got to pay them. Is that hard? You got to go get a prescription drug, well, someone has to pay them. It's called one payer, single payer. I'm going to give you some examples before I go into the bill about what's single payer. The United States Congress is single payer. And it's interesting, the most vociferous voices against single payer are part of our single payer system. All right. What's police? Single payer. What's fire? Single payer. What's public school? Single payer. What's the post office? Single payer. All right. What's the military? We've been doing single payer for over 100 years, man. It's not like new. It's just you have one payer. It's called the government. All right, so I'm going to go ahead and start with the actual explaining the bill. So, real simple slide here. I think you guys can all see this little orange. It says the United States per capita healthcare spending is more than twice the average of other developed countries. We're spending about per capita $9,024. Well, why is that? Dr. Law said it's because we run it like a business. You cannot run healthcare like a business. Okay? You want to sell McDonald's hamburgers and make a profit? Well, you can pay your workers $15, $20 an hour, but okay, but you can't run healthcare like a business because it will not work. These insurance companies and all the money that we're spending, when you go to the hospital, you're paying a 700% markup. 700% markup. So we got to get that number down, and I'm going to explain to you how we're going to get that number down. So next slide, please. This just has to do with performance. The Commonwealth Fund studied 11 countries and found the U.S. ranked last in overall healthcare system performance while spending the most per capita on healthcare. That's interesting, because common sense would dictate that if you spend more, you'd get better outcomes, right? Which means we have a dysfunctional system. Next slide, please. All this basically says is if you look at our health outcomes, life expectancy, maternal mortality, infant mortality, we're number one. You know what? A mother shouldn't die when she gives birth to a baby, should she? Death first year of life. Well, why is that? Because if you have been to a doctor for years and years and years, and you have health problems and you give a child, you can die. And if the child's not getting proper nutrition, if the mother smoked or drank because she didn't have preventative care because they didn't expand Medicaid in North Carolina, this means that we literally have a system of what I call premeditated first-degree murder. We are consciously killing people, and it's not like our legislators don't understand this. They are guilty of premeditated. You have first-degree murder and second-degree murder, right? All right. What's first-degree murder? It's premeditated. We had 1,700 people die last year. I think it was 1,700 because we didn't expand Medicaid. Do you think our state legislators knew about that? They did. If we had a single-payer system, here's how many deaths we'd probably have because you're uninsured, 0. Next slide. It's real simple. Why in the world do we have insurance companies making decisions for patients? Why should some young 21-year-old kid out of the Wharton School of Business tell me about what medical services you should get? Does that make any sense to you? Shouldn't your doctor be the one that tells you what to do? We have got to get the insurance companies out of the system, plain and simple. They gotta go. Why do people feel sorry for insurance companies? I never figured that one out. Next slide, please. Aha. Growth of physicians versus administrators. The reason why, when you look at the graph, the reason why you have this exponential growth in administrators, it's because of the paperwork that doctors and hospitals have to process. That's private insurance, Medicaid, Medicare, S-CHIP. So they have to hire all these administrators. So a lot of doctors get really burned out because they're doing all this paperwork. Right? In a single-payer system, that's taken away because it'll be electronic reimbursement. I'll explain that to you in a second. But we've all seen this. This is about the price of drugs. The drugs that I'm taking right, my copays are $600 a month, and I had to skip this month because I have a mother who lives on Social Security. I call it social insecurity because she can't live off of it. And so I have to skip my medical treatment that I really need because one of my pills that I take, my copay is $195. Without it, it'd be $1,000. $1,000. Well, you know, in Canada, or you can go to most any other country, the government negotiates down the cost of the drugs. That's why it's cost prohibitive. But, you know, $13.50 to $7.50, don't you think that's a little bit high? That's a cancer drug. Yeah. Now, where I'm from, we call that insanity. Next slide, please. Oh, my favorite. Health insurance company CEO. Let's look at Brother Mark Bertolini at Aetna. That's a good gig when you're making $41.7 million. Now, do you understand why premiums and deductibles cost so much now? I'm sorry, but you cannot pay a CEO of an insurance company that much money. I remember there was one CEO that made $1 billion a year. Again, you can't run healthcare like a business because their profit margin is directly commensurate and correlated with your premiums, deductibles, co-pays, because, you know, Mark can't live without that $41 million. He's got to have 12 yachts, not 5. You know? So, you know, if you get rid of the insurance companies, you get rid of their salaries. Okay, next slide, please. It's real simple. Businesses are paying way too much for health care. A lot of businesses actually move to Canada and Europe because they don't have to pay as much because they have single-payer systems. We'd be much more competitive internationally if we didn't have to spend so much on health care. And when we first we ran the numbers on 676 and 203, what we found is that the employers would have paid maybe about half than they pay now. These aren't lightweight business guys, right? You know, when you got CEOs saying that the Europeans are more competitive, or the Canadians, or the Taiwanese because of healthcare costs, we should probably listen to them. Next slide. What they're saying is if they didn't have to spend so much in healthcare, they could invest in employers' pensions or new products and so it's common sense. Next slide. Aha. Worried about not being able to pay medical costs for an illness. 60% of Americans are worried. 60%. That's way too many. What do you think that is in Taiwan or Europe where they have universal health care? Maybe 0, right? Now I have to worry, and I don't think it's a human rights violation that I have to worry. I think the United States should be sued in the court of The Hague for a human rights violation, but for not providing health care. Next slide. Now this is kind of shocking. In the next 10 years, we're going to end up spending $46 trillion on health care. $46 trillion. That's because we have a corporate system. We have to go to single-payer system. $46 trillion on health care? Wow, man, that's just a little bit too much. Next slide, please. Now, this is the most important, I think, part of the presentation. There's 2 different tributaries that we can take for health care. We could do the same dysfunctional system that we have now, which is basically private insurance, Medicaid, Medicare, S-chip, and it's called DISH. DISH is the disproportionate share. That's money you give to hospitals so they can cover the uninsured. Or you can create a big, gigantic trust fund, and that's called single payer, Medicare for all. And I remember there was a woman from Princeton, her name was Dr. Sumei Chung, and she said, Joel, you got to understand, trust funds are very powerful. Has Medicare ever gone broke? Nope. Has Social Security ever gone broke? Has it bankrupted anybody? You know who's bankrupted American people? Private insurance companies. That's who's bankrupt. People are always saying, well, if we go Medicare for all, it's going to bankrupt the nation. Can we just admit that the private insurance companies was the second leading cause of bankruptcy before Obamacare? Now, I'm going to show you something. This is someone's Medicare bill. Her name is Beverly Hummel, a very close friend of mine, lives in Bethesda, Maryland. And her bill was $11,000. And her copay for Medicare, this is with a supplemental, called a Medigap policy, It's $15. Now here's mine, my last copay. Oh, what does that say? It's only $833. Then I got another one for, what does that say? $150. Now after a while that adds up, doesn't it? And even though I was on the congressional plan, which is supposed to be the best plan, I still owe $18,000 from the congressional plan. Go with the trust fund. Taxpayer finance, they're very powerful. Because insurance companies are these teeny little fragile, they're not even trust funds because you can't trust them, right? Wouldn't it make sense to have a really large trust fund with dedicated revenues that could then pay your providers? And that's the choice that we have to make. Taxpayer financed, trust-funded, universal single-payer health care, or the same system that is broken and will never work. And by the way, you can do health care across state lines, you can try everything, competition, it's not going to work. If it hasn't worked since World War II, then why is it going to work now? Okay? As long as there's private insurance in the system, it won't work. Next slide, please. My favorite topic, the myths about expand and improve Medicare for all. It's going to cost too much. Wrong. We've already seen this slide that said that we're going to spend trillions and trillions of dollars with the current system. With the reason why you have to go single payer keeps costs flat. This is the most important component of single payer. Right now, our cost exponentially increases each year because the hospitals can charge whatever they want, doctors can charge whatever they want. Under a single payer system, the government negotiates with the doctors and the hospitals annually what their budgets are going to be, and so you keep the costs flat. That's the biggest problem with our healthcare system because a hospital and a doctor can charge you whatever they want. Quality. What a universal system has proven around the world is quality actually goes up, not down. Quality's pretty poor in America when a third of the people can't get health care. Wait time, if you look at H.R. 676, it's specifically written in the bill that there has to be adequate funding for staffing, so you get the quality care. That's what 676 was all about, quality care. If you go to the bank and there's one teller, you're going to wait for a long time, right? If you have 6 tellers, you'll wait less. Waiting lines only happen when you don't have enough doctors, nurses, infrastructure, or technology. Let me repeat that again. Waiting lines only happen when you don't have enough doctors, nurses, infrastructure, and technology. We got plenty of infrastructure. We got plenty of technology. So they'll say, well, in Canada, if you do a hip replacement surgery, you got to wait a year. Guess what? We don't live in Canada. We live in the United States. We have a $16 trillion gross domestic product. We have plenty of surgeons that can do hip surgery, right? So all you have to do is make sure you have proper investment. If you invest $780 billion a year in the military and less in the VA, then you're going to have poorer outcome. It's all about investment. It is not 676 is not a government takeover. It's privately delivered, publicly financed health care. The only thing that changes, actually, it's the same system. The only thing that changes is your card won't say Blue Cross Blue Shield. It'd say Medicare for all. And then the hospitals would receive what's called a global budget. I'll explain that a little bit later. That's like a public school. It's going to get an annual budget based on their expenditures. The Republicans are always talking about government takeover, privately delivered, publicly financed. That's what Medicare for all is. Elimination of choice under 676, you get your choice of doctor, physician, et cetera. Under the current system, choice is limited if you're part of a network or HMO, correct? Next slide. Under the bill, it covers all residents in America. You could go to any state in the country and just show your card, you're in the system. Nobody's excluded. It's a comprehensive benefits package. It covers anything that's medically necessary, preserves the private delivery system, no financial barriers to care, because you're improving Medicare and you're expanding it. You're not creating a new system, you're expanding and improving an existing system. But the main thing we wanted to create for 676 was no financial barriers to care. Because that's the biggest problem in America is the barrier, it's financial. Next slide, please. In terms of the basic features of our system under 676, you don't have to pay out of pocket. And that's really the expenses that are killing people is your deductibles. So I just talked to a woman on the way here who said her deductible was $5,000. That's crazy, isn't it? Co-pays, deductibles. So that's eliminated under 676. You show your card. Once you show your card, you leave, and then you're reimbursed. The doctor is reimbursed. The hospital's reimbursed. If, let's say, I have sleep apnea, I sleep on a little machine at night, they get reimbursed all from the push of a button. Next slide. Well, I did miss one thing that's very important. You can't pass a bill in Congress unless you protect the workers that are in insurance companies or hospitals. They would be transitioned. The bill is very generous. They get 2 years of their salary, up to $100,000. They can still get unemployment because you want them to have a soft landing. And they would be the first to be retrained and rehired. Because when I was working in Congress, the first question I used to get from a staffer, it wasn't about health care, it was what about the insurance, the people who work in insurance? That was the only question they used to ask. Next slide. Covers everything. Long-term care, dental. Right now, Medicare doesn't cover dental. Doesn't cover hearing aids. Our bill does. Inpatient hospital care, chiropractic. It would not cover cosmetic, though, surgery or braces. That you could do through private insurance. Next slide. I'm going to cruise through this so we can get to the questions. Yeah. This is very important. What's the question that you probably get more than any question is how do you pay for 676? We need to update the numbers, and Bernie Sanders tried to update the numbers. He couldn't find anybody to update the numbers. There's a group out of D.C. and Northern Virginia called the Lewin Group that could update the numbers. But in order to really win this argument, we're going to have a high-level group of economists, healthcare experts to really explain how we're going to pay for this program. We have to be able to do that, and that's something that we can do actually as activists on the outside. But basically, you have a trust fund, and the way the program would be funded would be through a payroll tax. Right now, you pay 1.45% of your payroll. That would go up to about 4.75%. That's the employee and the employer. That means you're going to know exactly what you're going to pay each month. So that 1.45% that you're paying now goes up to 4.75%. And if you run the numbers, if you look at deductibles, co-pays, cost sharing, it's a much better deal. There would be a small tax on stock and bond transactions, over $100. I think it would be 50 cents on the seller, 50 cents on the buyer, 5%, I believe, tax on those who are the top, wage earners. So 95% of the people are going to pay less than what they're paying now. And then there's a lot of different revenue streams that's untapped. A lot of companies have loopholes that everybody, I think, knows about. There's carbon taxes, tax carbon emissions. There's what's called the death tax. Just reverse the Reagan and reverse the Bush taxes, and there you go, you got it. And if people say, well, we're going to run out of money, you can't be the richest country in the world and then the poorest country in the world at the same time. Did everybody understand that? Our gross domestic product is $16 trillion. We're the leading exporter of oil. We'd have the Bentley, the Rolls-Royce of healthcare if we did this right. If we're negotiating down the cost of prescription drugs, if we're negotiating down the cost of hospital care. It all goes in that trust fund. And all you got to do is the trust fund, it's electronic, so you're a doctor. Let's say I go to Rebecca, let's say she's my doctor, right? I show her my card. She says, what's up, Joel? I say, I got a headache. Oh, well, I'll treat you. She treats me, she presses a button, and then she gets electronically reimbursed right into her bank account. Does that make sense? You go to Chapel Hill, one of the hospitals here, Chapel Hill Hospital. They're going to get a budget from the government based on what their annual expenditures are. That way, they don't have to sell stock and do all kinds of crazy things to get money. They're going to get a budget based on what they need, based on the nurses that they need, based on the physicians that they need. And when it comes down to it, if you look, hospital facilities, physicians, medical supply companies, long-term care, pharmacy, that's basically what you're paying for. You show them your card, you get your product, and you leave, and then they get paid. Does that sound? Now, can I ask you all a question? Is that hard to comprehend? You know why? Because that's what Medicare does right now, and Medicaid. Medicare was established in 1965. It took 6 months to put the program into effect, and they did it with index cards. That's how. And the doctor said it's going to blow up the cost of health care. They were wrong. They said Obamacare would be job killing. Remember that? Yeah. Not killing, job killing. And imagine today someone said, well, I think we ought to have public schools. Well, there's too many children, and there's going to be long waiting lines. I mean, believe me, we can do this because trust funds are very, very, very powerful. Next slide. By having a nonprofit system and negotiating down the cost of drugs and having global budgets, those are really the key features of cost savings, why you can keep it flat instead of it going up. You know how much a long-term care center costs for a senior citizen? It's ridiculous, the amount of money, right? You give them a global budget based on what's fair. You negotiate down the cost of prescription drugs. You're negotiating down the cost of technology. My CPAP machine costs $4,000. It's a piece of plastic with a motor. That's crazy. An MRI costs $1 million, $700,000 to put into effect. Does that sound a little high to you? $1 million? So you're creating a rational, simple, effective system. Next slide. And this is what I talked about before in terms of when we transition, that we want to be a safe landing. We don't want people out in the street and not having housing and health care and a job. And, I think, if you look at, with the current Medicare system, about 10,000 people are enrolled per day. Medicare for all is the soul of simplicity. Once you are enrolled, you are covered for life with no financial or administrative barriers to care. So you have to fill out a two-page form. You fill it out under 676. Then you get the card, and you use it from birth to transition. Doesn't that make sense? Next slide. This will take 30 seconds because it's almost, I think I'm going to do about 2 more minutes, and let's go for Q&A. How's that? Let me explain ACA in 70 seconds. 16 million people get Medicaid, 15 million people get a voucher for private insurance. Community clinics get more money. Then there were restrictions placed on private insurance. At the age of 27, you could stay on your parents' plan. You couldn't discriminate against pre-existing conditions. So those of us who worked on ACA, our plan was to get something passed in Congress and then steer it to single payer. Now that's the honest to goodness truth. What President Obama, hello President Obama, if you ever see this, Obama wanted to expand Medicaid and Medicare. That's what he wanted, okay? ACA was Kennedy and Waxman from the House, Kennedy from the Senate. They saw that the Massachusetts plan, which was Obamacare, got passed, and they were like, let's replicate that. But from the progressive wing of the party, we wanted to just get, and I have to tell you, there were 2 or 3 of us who helped get this bill passed because there was a time when Obama was going to take the bill back. And it would take too long to tell you the story, but there were 3 staffers. I was one of them, and behind the scenes, we made sure that we got the bill passed. I organized a million call-in march through Move On to the president's office to make sure that it wouldn't be taken back, because Rahm Emanuel was worried about the politics of this. But it was Michelle Obama and Nancy Pelosi, 2 strong women, who made sure that bill got passed. I just have to tell you that. The main difference between Bernie's bill, thank God for Bernie's bill, right? Bernie Sanders. They cover abortion, 676 does not. They do allow for-profit HMOs. The reason why, and the Senate is more conservative than the House, so he had to write that bill to get more senators to sign on to the bill. It's tactical, but Bernie, it was really cool. His car, we used to park cars next to each other. He'd say, "Good morning, Joel." He's real intense with like 50 bucks in his hand. And, this dude is as progressive. I shouldn't call him a dude. He's, a senator. But he wants to do the right thing, but his strategy is to get the discussion going. Next slide. It's very, very clear what this says, and that's the majority of Americans would like a single-payer system. Right? Yes. All right. Next slide. Why aren't we moving why aren't we moving faster? I think I'm going to conclude with this. The reason why is because unless we become the Sarah Club of single payer or the AFL-CIO of single payer, we're not going to win this fight. We have to staff up and professionalize the single payer movement because we don't have enough organizers. I remember Ralph Nader told me if we had 10 to 15 organizers, we could win it in 3 to 5 years. But when I was in Washington, I was the only person working on single payer full time. So right now, the single payer movement also has to be way more diverse. It has to be more diverse. But once we can get, if you want to compete against the pharmaceutical companies and the Republicans and the private insurance industrial complex, you better have $500,000 in the bank. Right, doctor, who's going to run for Congress? You got to hire organizers, and I think what we have to do is we have to have teach-ins across the country. We have to explain this to everybody, because there's too many myths that the insurance companies promulgated. They probably spend $1 billion against single payer because they know it works. And so it's up to us, and I'm hoping in Chapel Hill, I think this could be an epicenter of the movement. And let's say Rebecca got paid a good salary to teach this, and some of you, right, or, and what we're going to be doing, let me give you the good news. I'll be speaking in Asheville. Someone came up to me and said, "Can you speak in Asheville and Hendersonville on this?" I said, "Yeah." But NAACP is going to start having speakers from across the country. They're going to be speaking all across the state. So what you're doing here is historical. There really wasn't even a PowerPoint on single payer that even talked about 676 and single payer. Rebecca and her crew put the, can I say your crew? So, we're taking it, as Stevie Wonder would say, to the higher ground, to the next level. But people are going to have to start opening up their checkbooks, and we're going to have to professionalize this. We need an office in D.C., New York, and other places, but we have to staff up and get more professional. But there is no answer. This is the only way to go. Thank you for giving me an opportunity to talk tonight.